Good morning, everybody. Thank you to the Brain Tumour Charity for inviting me to speak. What a great venue. I hope this is going to be a great day as well. I really enjoyed that first talk as well, Jen. Thank you. So, I work in NHS Lothian, where I am currently a liaison psychiatry trainee. Liaison psychiatry is hospital-based psychiatry, so I see people who are already admitted to hospital and who have medical problems, and also have psychological or psychiatric problems. As well as that, I have a background in researching depression and other psychiatric issues in patients with brain tumours. So I'm going to give you a little bit of evidence-based information, but also some clinical tips that I've picked up along the way. And the title is Recognising and Managing Mental Health Conditions in Those Affected by a Brain Tumour. This is a huge topic, and in 40 minutes there's absolutely no way that I can go into a lot of detail and breadth to cover everything. So what I've chosen to do is give you just the heads of the main points of some of the most common issues and conditions which I think affect people with a brain tumour. We'll start with a little bit of background focused on general emotional distress and some of the reasons for that. And then I'll speak something about depression and anxiety, delirium and cognitive impairment, personality change, and at the end, I will go off beam a little bit and suggest something a little bit more controversial and hopefully trigger some discussion. So, it is absolutely established that brain tumours increase the risk of mental ill health. The frequency of emotional distress, however you want to cut it, in somebody with a brain tumour is much greater than in the general population. The frequency is greater than in some other cancers as well, although interestingly, not all. For instance, if you look at depression, the frequency of depression in brain tumours is higher than in other cancers, such as lung cancer, but it's no higher than in other cancers like head and neck, or cancers of the female genital tract. Brain tumours have the highest risk in the period running up to when the cancer is diagnosed of having been admitted to a psychiatric hospital. And they have the third highest risk of suicide in the first 12 weeks following a diagnosis. So this is a big problem. You'll see down here and on the slides, for those of you who are able to see, I've referenced the facts where I can, and the references are at the end. I'd be very happy to send anybody the slide of the references if they'd like to read more. So to think about emotional distress for a minute, many of you will be familiar with the distress thermometer. This is something that originated from America and has kind of spread around the world. It's a visual analog scale where you self-report your distress from 0 to 10. And I studied 153 patients some years ago and looked for their distress at different time points. And what I found was that high distress, marked by a DT score of more than 4, was very common in more than a third of patients shortly after the diagnosis. And interestingly, although it's not on the slide, patients who were highly distressed stayed distressed through the period of time that I followed them up, 3 months and 6 months. So high distress persists in these people. Who's most at risk? Patients with a lower functional status, people who are younger, those with epilepsy, and people who also have depression. We know from research in cancer, in other types of cancer, that emotional distress can peak at certain key points. So if you're thinking of times when you might be wanting to be a little bit more aware that the person might be experiencing distress but not vocalizing it, these are the points to think about. Obviously diagnosis, I think we would all think about that. End of primary treatment is something which I think if you work with patients, you know very much about. There is a sense of falling off the end of a cliff when you reach the end of your primary treatment and you're left to almost to fend for yourself. Then again, after a period of time at recurrence, and then, if the cancer progresses, at palliation. The Brain Tumour Charity have fleshed this out in a really nice qualitative way using their Losing Myself, which is a copy of which is in all of your packs, and I would strongly encourage you to read it because it makes the case much better than any numbers can. So for instance, you hear the qualitative difficulties that people have, feeling like a burden. This is from a man, no longer the capable man I once was. Seizures, making the person lose confidence and scared to be alone and having anxiety. Feeling frightened by behavioral changes and relationship difficulties. So there are many reasons why people may have mental health problems. They also have multiple concerns. This is a piece of work that we did with a very good Dutch medical student who came to work with us for 3 months. We developed something called the Patient Concerns Inventory, which is effectively just a problem checklist linked to a question prompt. Okay, that was the nub of it. And the problem checklist was very largely based on the distress thermometer, but added in things that we thought were more likely to be problematic in people with brain tumours. The distress thermometer, for instance, the problem checklist doesn't mention epileptic seizures. So using the DT in patients with brain tumour obviously isn't going to necessarily capture their main problems. So we developed this. We asked patients what their main problems were, and I know you won't be able to read this, but I'll read out for you some of them. At the very top, fatigue, then memory, then fear of the tumour coming back, then concentration, followed by sadness, low mood or depression, driving, which is a social issue, sleep, anger or irritability, and then we get to the first physical symptom, headache, weakness in arms or legs and vision, and personality change. So most of the top 10 or 12 concerns that people had related to mental health or aspects that might influence mental health, such as social functioning. When we analysed what the patients were asking in the questions, we basically asked patients to take the main problems that they'd had and then think about the questions they wanted to ask. This reflected what we'd seen in the data here. Most questions, more than 2/3, were about the person's symptoms or social issues, the meaning of their symptoms. They didn't know what their symptoms meant, and that was giving them emotional distress. Whereas relatively few questions were about the kind of more technical procedural aspects that in clinic, in a busy clinic, doctors and nurses might feel it's important to impart information about. So with that set up, I'm going to talk a little bit now about depression and anxiety. Now depression, clinical depression, is a huge hidden morbidity in this population. We've already heard very eloquently from Jen talking about her depressed and anxious difficulties. And in the study, again from 155 patients, the 6-month prevalence, so the number of people who had depression over 6 months, was 21% in our study in Edinburgh and Glasgow, which tallies very well with the rest of the literature. It's about average when you average out the spread of depression in the literature of brain tumours. Which, if you just assume that Cancer Research UK are right, that there are 10,000 new diagnoses every year, that's 2,000 depressed patients, newly diagnosed depressed patients every year in the UK. So that's a very large hidden morbidity, I think, in many cases. And it persists, and it affects quality of life. Again, the people who are at risk are the people who have low functional status, who have a history of depression, and probably, I think, who are on steroids or who also have cognitive impairment. Now, depression is a clinical syndrome, and to a psychiatrist, it means something different to what it might mean to the man in the street, or perhaps even to a neurosurgeon, say, for instance. So when I started the study, several people independently said, well, what are you studying that? I'd be depressed if I had a brain tumour. And what they meant was they would be sad. They would have grief. And I understand that. And of course, that's right. But it's not how a psychiatrist thinks of depression. I'm sure some of you already know this. But we have a syndrome. So you need more than one symptom to have a clinical diagnosis of depression. One of the top two, depressed mood or loss of interest. And then it's like one from the top, two from the bottom in countdown. But basically one from the top and then 4 from the bottom, or in any combination of appetite, sleep changes, concentration difficulties, physical or mental slowing, which is called psychomotor retardation, guilt, fatigue, suicidal thoughts. And you can have this in many different combinations, it will still give you the same diagnosis. And you can see this illustrated very clearly here. These are from the patients that I saw in my study. There's 21 of them down the side. And along the top, we've got the different symptoms of depression listed: mood, anhedonia, appetite, sleep, psychomotor retardation, fatigue, guilt, concentration, and suicide. And this is effectively like a genetic heat map, showing in red symptoms which are not present, and in green where the symptom is present. And you can see several things from this. First of all, looking at the chart as a whole, you can see how different the syndrome of depression looks in a kind of a bird's eye view when you look at all of the symptoms together and all of the people together. This is not the same disorder, but we call it depression. So take away from this slide that depression is an umbrella diagnosis, which is another way of politely saying that it's imprecise. If we're trying to work out what's going on in the brain, it's very difficult to model this because there are so many different ways that someone can be depressed. Secondly, look at this little group up here. Some people can be depressed but not have sadness, not have any low mood. They're depressed because they've lost interest in activities. And I noticed in my study an interesting group of people who were very clearly had just completely lost interest in all activities. But when you asked them, do you feel sad? No, don't feel sad. But they just sat there with no motivation. There is an argument, an academic argument, that these people should not be called depressed. But again, there's no fundamental lab-based data really to back that up. The third thing to take away, a very important thing, look how rare suicidal ideas are in the people that I saw shortly after diagnosis. So when suicidal ideas are present, you must take them seriously. So clinically, and this is purely my clinical tips from interviewing a lot of patients over the years for depression, diagnosing depression is very much a matter of clinical judgment. It can be a difficult clinical judgment. I would at least wait 1 month from the diagnosis, because you've got to allow at least a period of time for a natural grief reaction to settle, unless the person is very severely depressed, suicidal, or expressing things that might be psychotic symptoms. I would focus on the severity and the persistence of symptoms. This is key. Grief comes in waves. Okay? Sadness of depression is persistent and pervasive. It's there most of the day for most days of the week. That's my general rule of thumb. Most of the day for most days of the week. Some degree of loss of interest is normal because the people cannot do what they have previously enjoyed doing. They can't drive, for instance. Some guilt is normal as well because they're not able to follow the same social roles that they used to be able to follow, or perhaps support the family in the same way. Suicidal thoughts should always be taken seriously, but most importantly, get a collateral history. It's very handy. A lot of people in this, particularly pre-diagnosis and early post, have some cognitive impairment. So it's very worthwhile asking their carer or relative to back up what they're saying. Some of you may be aware that you can screen for depressive symptoms using different tools. Here in this little box, I've just put the ones which are validated or even partially validated in patients with brain tumours. Okay, so these are the ones with the best evidence base for using in brain tumour patients. They are the Hospital Anxiety and Depression Scale, the PHQ-9, and the Depression and Anxiety Symptom Scale 21, DAS-21. The DAS-21 paper was just out last month. So you can have a look at those. The references for this are at the end of the article as well. Think about other potential diagnoses. Adjustment disorder is the obvious main differential, but delirium, organic personality change, or any medical problems such as anemia, thyroid dysfunction, or pituitary disease. The best way to treat people with depression and a brain tumour, unfortunately, isn't known because there's no randomized controlled trial proven positive study or intervention in this population. These interventions, some drugs, methylphenidate, oxcarbazepine, ginkgo, and donepezil. Don't worry too much about the details of what they are, but these are different types of drugs. There's some evidence, but the studies are really, really low quality. They're open label, single arm trials, and you can't draw any conclusions really from them about how effective they are. Similarly for massage therapy, acceptance therapy and telephone-based support, although there is a randomised controlled trial going on for acceptance-based therapy in Australia. A recent RCT found that internet-based guided self-help was not effective. Unfortunately, that study was underpowered. So it's difficult to draw conclusions from that. And there is some evidence that a tailored psychosocial intervention, which I'll talk about a little later, may be effective for some depressive symptoms. Again, we can discuss the details at the end if you're interested. Unfortunately, we fall back on the National Institute for Clinical Excellence's general guidance of treating depression in comorbid medical conditions, which is antidepressants and a talking therapy, CBT, interpersonal therapy, or so on. I've added exercise because I think exercise is likely to help. As Jen said, she's found that it's helped with her fatigue levels. And it's a general positive thing, I think. It's unlikely to be harmful. So very briefly, I'm going to go through a quick case study. Sorry for putting all the details on the slide, but I'll hit the main notes. So this is a 57-year-old lady that I was asked to see last month on the ward in Edinburgh, neurosurgical ward. She had presented with a subacute history of forgetting her skills in her work as a bank clerk, also with labile mood and irritability. She had a history of anxiety and depression, and imaging showed a meningioma in the left frontotemporal area with edema and mass effect. So she was started on dexamethasone, and I was asked to see her when she was in the pre-admission clinic because she seemed to be anxious and depressed. And what she described to me was low mood, fatigue, poor sleep, poor appetite, and she was often apologising for these things too, which I count as low self-esteem or guilt. And she was also extremely anxious, hyperventilating, very tense, and shaking. Our arms and legs were shaking. There was no severe symptoms such as suicidality, hallucinations, or paranoia. And so we diagnosed recurrent depressive disorder, because this lady had a history of depression, current episode of moderate severity, and also a generalized anxiety disorder. I think explaining it, she had a constitutional tendency to these things. She had had depression and anxiety before. She also had a large tumour in her temporal lobe. And the last time I've seen a lady as anxious as that, there's only one other patient who's anywhere near up there with how severe that anxiety was. She also had a left temporal lobe lesion, interestingly. She had had a dental abscess, scarily enough, from a dental treatment, and developed a temporal lobe abscess, and then became extraordinarily, uncontrollably anxious. And also, I think dexamethasone was probably contributing to her symptoms. So what we did to treat her was we gave mirtazapine, 30 milligrams. Mirtazapine's a sedating antidepressant, which is useful because it helps people sleep. It also improves their appetite through one of its mechanisms of action, and it treats depression. And diazepam, low dose, regular diazepam, just as a short term to cover her really up until the operation that was planned for a couple of weeks. And I went to the neuro-oncology nurse specialist in Edinburgh and asked her if she would very kindly see this patient before the diagnosis was made histologically, and she agreed to do that too, and signpost her on to other support services. So that's how we managed that. I'm going to have to move on for reasons of time, but I'm very happy to talk about any of the issues that are raised in any of the conditions I talk about, either at the end in questions or later on through the day. I'm here all day. So to think about delirium and cognition, cognitive impairment after brain tumour is really common, very, very common indeed, and it takes different forms. So you've got delirium, you have maybe impaired mental capacity, you might think about that, or you could have a more long-lasting chronic impairment. I'm only going to talk about delirium, and the reason for that is because it's the one which I see most of in the hospital. Delirium is a sudden onset, fluctuating confusion. Sudden onset and fluctuations, that's the absolute critical thing to catch. More often than not, if you've got something that's sudden onset and fluctuating, it's going to be delirium. The problem is that delirium is again, a basket diagnosis. There's many different causes, and you have to try and work out what the cause is. Luckily, though, there is a screening tool that you can use. It's hidden away down in the corner. It's called the 4AT. It's freely available, and the link is at the end of this presentation. So I think delirium, this is my clinical impression, I think people are at increased risk soon after diagnosis for various reasons. They're post-op, there are steroids on board, high doses often. They may have an infection, and they're getting radiotherapy as well, which causes swelling within the brain. And then as they progress through their treatment, the risk of delirium dies away. And it's really quite rare, I think, in patients who are stable outpatients, unless there's something else going on. However, at the end of life phase, in patients who come to that point, it is a big problem. A big problem. More than half of patients probably have delirium at the end of life. Again, steroids, infection, opiates, disease progression, and catheterization are all issues here. It's difficult to work out the risk factors for delirium because it's variably diagnosed in all of the research studies, so it's quite hard to absolutely pin them down and get all the studies lined up in a row so that you can do a meta-analysis. But there seems to be general agreement clinically and in the literature that the people who are most at risk of delirium are older, cognitively impaired, they have or may have an infection, they're on certain medications like opiates, any opiate medication increases the risk, or anticholinergics, any anticholinergic medicine too. And they may be immobile, and often they have a catheter. So when I go on the ward and I say, it's delirium, treat the cause, the medic or the surgeon kind of looks at me like Willy Wonka here and says, really? Tell me more about that. Because unfortunately, that's the answer to how you treat delirium. But the list of causes, goes on and on and on and on. And so you have to find out the cause before you can treat it. And that's the job of the medical team with their investigations. However, there's a lot that we can do. And I include myself in the nursing and AHP role here because psychiatrists are not treating the delirium itself. We're there to provide supportive treatment. And we advise people, and we can help with things like providing a side room, making sure it's well lit, using a clock or a calendar, sensory aids if the person has poor eyesight or is hearing impaired. Very helpful to rationalize meds and take off what's not needed. Very, very helpful too to have one or two well-known staff treating the patient. It tends to calm them. And to use familiar objects from home. Only where necessary to maintain safety would we recommend medicines. There has to be a risk-benefit because there's no medicine that's been proven to treat delirium as such. We only use it to reduce the level of behavioral agitation that might otherwise put the patient or others at risk. And we would use a low-dose regular antipsychotic, for instance, haloperidol, very good, 1 milligram BD, or olanzapine, 2.5 milligrams at night, and PRN as required. Try and avoid benzodiazepines, and try and stop opiates and anticholinergics. Here's a case study of a patient that has stayed with me. Again, I saw him just a couple of months ago, 74-year-old man, recently diagnosed following cognitive slowing and poor concentration with no past medical history, who had a right frontotemporal lesion, which was debulked and a pathology confirmed glioblastoma multiforme, grade 4 tumour. The aim here was for 40 grays and 15 fractions. He was tearful and emotional following diagnosis, but his MMSE was okay. So they went ahead with the radiotherapy planning. And once they started radiotherapy planning, he was at home and he gradually deteriorated. He gradually became less mobile and more confused, and gradually more irritable and verbally aggressive over a period of 2 or 3 weeks. And so the team gradually increased his dexamethasone to try and get on top of it. And that didn't really work. And they then decided that they were going to admit him to hospital for the radiotherapy because they thought it would be the easiest thing. And I don't understand this. A repeat CT head showed absolutely no progression in his tumour since the operation. So what was going on here while he was developing these gradually worsening symptoms is not clear. However, an episode shortly after he came in, he became unresponsive for a couple of minutes, and they gave him 16 milligrams of dexamethasone. And within 24 hours, he was really mentally unwell. He was very agitated, very labile in his affect. He was being nursed by 3 nurses on a general oncology ward to maintain his safety. He was disorganized. He was sitting on the edge of the bed without any clothes on, paranoid and aggressive. He was clearly visually hallucinated. And this followed a fluctuating course. He was awake at night and he was drowsy during the day. So I went to see him, and the risk factors included having a brain tumour, having radiotherapy, being on steroids, okay, that's already there, plus being on Oromorph. He had a phimosis of his foreskin, a tightness of his foreskin, which might have been causing him pain. He had a catheter and thrush. So, unfortunately, the take-home message here is mixed, and one of the messages is that delirium can be very difficult to manage, but I'll give the positive message at the end of the slide. So we diagnosed a multifactorial delirium, and he turned out to have a UTI. So the treatment, treat the cause, okay? Treat the UTI, treat candida, treat the phimosis. In case steroids are contributing to this, reduce the steroids if you can. In case Oromorph is contributing, stop it. And we started olanzapine at this dose because he was quite agitated. He was nursed. The nurses were fantastic, and so were his family. They came and they sat with him for hours and hours every day and really were very helpful and very understanding. However, as agitation continued, and he was throwing cups of tea at the staff, he thought the consultant was trying to kill him. He was very confused, and so we increased the olanzapine. Unfortunately, he remained cognitively impaired. His thought processes were disjointed and tangential, and he was seeing complex hallucinations and people in his room that he was talking to. So the olanzapine was increased again. All the while this was going on, he was getting radiotherapy. I have no idea how he tolerated it in the mask, but he did, and he completed a course of 6. He ended up getting 6 fractions, a palliative course, but he completed the course. And ultimately, we gained control of his positive symptoms. He wasn't hallucinated, agitated, behaviorally disinhibited. Unfortunately, he remained very cognitively impaired and still does. So, to switch gears slightly and just consider, although not entirely, and consider personality change. Personality change is a very difficult complication, both for us to treat and manage, to advise, and also for families and carers. Here are some questions that carers and patients living with a brain tumour have asked in a little bit of research that I'm involved in at the moment. How can we understand each other's point of view? Why do the problems cause strain on partnerships? Why do we hurt the people closest to us? Why can't we ask them to help? Do I say too much or not enough? I will try to answer those questions at BNOS. If you're coming to BNOS, then come along to the nurses session there. Personality change is very frequent. I won't go through every single line on this slide because there's quite a lot of data here. But in a nutshell, we range from 16% up to 73% in the studies that have attempted to measure it across different diagnoses of brain tumour types. Primary central nervous system lymphoma is a big problem with that. In children as well. And it has a significant impact on the qualitative experience of living with a brain tumour. So it's a big problem. And I think, actually, it is one of the biggest problems in terms of mental health. Why do I say that? Well, that's because even less than in depression and delirium, there is very little evidence to guide our management of this problem. I I parsed the literature, did a search, looked at all of the abstracts that mentioned personality change, and I broke them down to say what type of study they were. Okay? Most of them are case reports. There's a little literature on the consequences of childhood posterior fossa surgery, which is fascinating. Unfortunately, I don't have time to go into right now. But there are very few intervention reports, and I think only one randomized controlled trial. That randomized controlled trial was done by this lady. Her name is Tumour. She is from Melbourne, I think, in Australia. I'm collaborating with her on something else, but she has developed the Making Sense of Brain Tumour program. It's an individually tailored program based in psychoeducation, cognitive rehabilitation, and psychotherapy. It's kind of a modular thing that you tailor to the needs of the individual patient, involving couple and family support. And it showed some evidence of improvement in quality of life and depression and carer stress. But that's the only, it was a single centre randomised controlled trial, and that's all the evidence we've got. This lady here, Sue, is again also an Australian. She's a clinical oncologist, and she has published on behavioural consultancy, which is kind of similar, but is slightly different in that it involves a carer training workshop that carers come to hospital for, and other things such as relaxation techniques and communication skills. The evidence for this is at pilot level data at the moment. But there are behavioural programmes being developed to address personality change specifically in brain tumour patients. I did wonder whether we could adopt treatments that were used by other patient groups. So you have some demented, if you have some literature in dementia, and here you've got something called functional analysis, where you analyse what happened before the behaviour itself and what happened afterwards, and you try and reduce the element of reward that the person might get from behaving in a particular way. You may consider drugs. Propranolol has the best evidence for treating agitation post-brain injury, and if we were to consider brain tumour as a brain injury, you might think propranolol is worth a shot. You could use antipsychotics. There are a few case reports of risperidone. Something else that's been used in dementia is cognitive reframing, which seeks not to address the behaviours directly in the patient, but rather to shift the cognitive focus and framework of the carer to a way where they are better able to accept the behaviours. It's probably something that should be done in tandem with actually addressing the behaviours of the patient, but there's a Cochrane review showing that this significantly reduces anxiety and depression with really quite a large effect size for a meta-analysis in carers. And if it works, it's worthwhile trying. So let's think about a positive way. Now, as Mugatu almost said, mental health is so hot right now. Those of you who are Zoolander aficionados will need no further explanation. Those of you who aren't, watch Zoolander, it's amazing. In Scotland, we've got our own Mugatu. She's even wearing the same colour, Nicola Sturgeon. And she has made mental health a priority for clinical services, which is great. In the UK generally, the royal family are spearheading the Heads Together campaign. And we have new ambitious charities that are seeking to reduce the stigma associated with mental ill health. And all of this is fantastic. What's also fantastic, I think, is the World Health Organization's definition of mental health. Okay, they define it like this: a state of well-being in which every individual realizes their potential, can cope, can work, and can make a contribution. Love it. Absolutely love it. And the reason I love it is because in medicine, generally, the whole healthcare, we're used to working on a deficit model, I think. We find problems. We find the problems and we fix the problems. But actually, what's going on at the moment in mental health, in the public sphere and at international levels, is much more about seeing the positive side of things and the potential and maximizing the potential of people rather than fixing a problem and then moving on.